Ooh, I was sick. I never been so sick in my life. I was sick. I don't know what I was sick before they done the first dialysis.
The remarkable thing about our experience at Genzyme is that all employees participate in carrying out our achievement towards our purpose. Clearly, our employees in our research and development organizations throughout the world have a profound impact on our ability to deliver to our purpose. So all employees, finance, regulatory affairs, quality control, everybody participates in what we are trying to do together.
I used to play a lot of sports, and all that stuff is gone now. I don't have the energy to even walk a flight of stairs some days.
It has become very important for the patients at risk for chronic kidney disease to know their number. And that's the catch-all phrase recently that we're trying to educate our patients both locally and nationally.
Most patients have absolutely no knowledge that they have risk factors or that they actually have kidney disease. And you want to be very careful not to hit them over the head with this information, but to actually educate them about what kidney disease is, what are the risk factors they may have had that would lead to kidney involvement, and help them understand, because their initial reaction is denial.
As the population increases, chronic kidney disease is increasing, and it is no longer something that just the kidney doctors need to worry about. Everyone needs to worry about chronic kidney disease.
In the last 10 years, we've seen several advances in chronic kidney disease management, including the introduction of alternative vitamin D analogs, phosphate binders. We've seen advances in our understanding of lipid management, proteinuria reduction, and anemia management.
The science around CKD, what's actually going on with these patients in earlier stages, I think, is starting to evolve and advance in what I think are very exciting ways.
In 2005, my doctor told me, my primary care physician told me that I needed to see a renal doctor because my kidneys were showing failure at that time. So I went to see the renal doctor, and mid-June, I think it was, of 2005, and he told me at that time that within 6 months I would need a transplant or be on dialysis. I have 3 kids, and they've been fantastic, thank God. But losing their mother and then being told that the father has kidney problems, needs a transplant, and going on dialysis. So it was an emotional roller coaster for me as well as my kids at that time.
Over the last 10 years, we have identified that the percentage of patients with chronic kidney disease in the United States are in the tens of millions, or the millions, yet only 350,000 of those patients actually survive to go on to dialysis.
Often these patients really need just an explanation of the fact that they have kidney disease. I think our patients need to hear that over and over again before they understand that.
What's really critically important is to identify for them the risk factors that they possess, that very tight blood sugar control if they are diabetics is really important. Their diet is very, very important. Their fluid intake is very important to prevent them from having edema. Very good blood pressure control is really very important, because the 2 most important risk factors for kidney disease are hypertension and diabetes. An emerging risk factor that has been identified is obesity, particularly childhood obesity as well as adult obesity.
Diabetic patients need to be screened early. Hypertension is not treated accurately, and this is where the diagnosis needs to start, so we need the help of our community and the primary care physicians, internal med physicians, to identify these patients who are at risk.
We try to make some changes early on. Things like asking them to avoid cola drinks, switching from whole wheat and whole grain products, which tend to be high in phosphorus. We talk to them about the time that's involved in transportation to and from the dialysis unit, as well as the time to set up. So it's a big chunk out of a day for them 3 days a week.
Along with being on dialysis, I mean, I do it 3 days a week, but I still have 4 other days a week where it can affect you as far as how you feel. You don't have as much energy as you would like to have. So you may get up one day and feel, I feel pretty good today, and then tomorrow you feel lousy. Yeah, I mean, the point where you don't even want to get out of bed. And it's a struggle, you have to get yourself up.
The last 10 years, I think, really has sharpened the focus on CKD and therapies for CKD, and also how prevalent it is, and what might be accomplished in improving patients' outcomes with CKD. The focus has been on dialysis, and I think we've made great strides in treating dialysis patients. There are new drugs. There are, I think, new approaches. Reimbursement systems, I think, globally have gotten better to treat the dialysis patient. And I think now we're also starting to get some early clues on some of the things that are going to be important as we start thinking about CKD in its earlier stages.
If you catch them in an earlier stage, you can control their blood pressure, you can reduce their proteinuria, you can treat their secondary hyperparathyroidism. You can do many things which have been shown to decrease the progression of their kidney disease and hopefully stall the process altogether, thereby delaying or actually preventing progression to later stages.
Educating primary care physicians is a central goal of what we do as nephrologists, and it really should be. And one of the most important outreach programs that I can see and that I use in my practice is professional education seminars, outreach, community outreach to physicians.
The patients that we are able to see earlier and treat their disease process before they hit dialysis, it makes a world of difference. There's decreased hospitalizations. They have an access. They should have an access. They should have had the opportunity to be told about all the different dialysis modalities and be able to make decisions while they are thinking straight instead of in the crisis of a brand new diagnosis.
We're at the threshold of discovering the multiplicity of factors that lead to chronic kidney disease. The discovery that chronic kidney disease actually is a major risk factor for cardiovascular disease and mortality in our patients.
The availability of CKD therapies for patients who reach end-stage renal disease has been huge with the proliferation of home hemodialysis units, as well as the different styles of peritoneal dialysis have afforded a lot more independence for patients.
I think one of the major implications with calcium and non-calcium based binders, when we have patients on vitamin D or vitamin D analogs, many times these individuals will have the propensity to develop hypercalcemia, elevated calcium levels. By using non-calcium based binders, we're able to control the parathyroid hormone levels, I think, more appropriately than if we had grams and grams of calcium-based phosphate binders in these individuals.
The identification that the serum phosphorus, to which we paid maybe not so much attention 10 or 15 years ago, how important the serum phosphorus is to the overall well-being of the patient, to its contribution to vascular calcification, to me has been really exciting science. One of the most important and what has achieved a national publicity is the importance of vitamin D metabolism and the abnormal vitamin D regulation in patients with chronic kidney disease. That has been almost a blockbuster observation of not only its effect on bone health and integrity, but also on mortality in the patients with chronic kidney disease.
So we immediately published a paper in Science saying that the kidneys are the sole source for the production of 1,25-dihydroxyvitamin D, and that patients with chronic kidney disease needed it, and the reason for their resistance to vitamin D was that they couldn't make it. And so therefore they needed to be able to get it as a pharmaceutical agent. And there's been novel analogs made, including vitamin D2 analogs, 1-alpha hydroxyvitamin D2 analogs, that have less calciumic activity but have the same benefit for bone health and for reducing parathyroid hormone levels that have now been developed for treating CKD patients.
I think the first opportunity is one of education. Given the fact that the focus has been so much on dialysis patients and also on the markers that we can measure, they're actually performance measures for dialysis clinics, getting patients within KDOQI target ranges and so on.
Genzyme's been instrumental in allowing us to go out as speakers into the medical community to the family practice physicians, showing them what things that our practice focuses on in managing their patients with chronic kidney disease, and giving them some insight as to when it's appropriate to refer them to the nephrology practice for follow-up.
Genzyme has been committed to identifying both the mechanisms for bone disease and chronic kidney disease, as well as identifying and developing treatments for the disease.
Genzyme has dedicated a lot of R&D dollars to develop new products to help our patients improve their outcomes and ease of taking their medications. And several of their new products, I think, really speak to that effect.
Genzyme has been extremely innovative in the development of therapies in making life simpler for our patients with kidney disease problems. This helps the patients, it helps us as educators and clinicians to treat this difficult disease process easier.
Genzyme's demonstrated through its history that putting patients before profits actually turns out to be good business. Genzyme's in a unique position to address the challenges of the dialysis patient because we have products that address two of the most important problems facing patients. We have Hectorol for hyperparathyroidism, and we have Renagel and Renvela for hyperphosphatemia, both of which are first-class products.
With the recent introduction of Renvela, we now have a sevelamer product with a carbamate buffer. So we have all the benefits of the sevelamer product that we already had in Renagel, but now with this carbamate buffer, the patients really seem to do well with it. In addition to that, Genzyme has a Renassist program, which has allowed some of our patients who don't have adequate insurance coverage to obtain Renagel and now Renvela through this program. And I've had several patients who have benefited from this. Also, in the last 10 years, we've had the introduction of vitamin D analogs other than calcitriol, mainly Hectorol. And these drugs have allowed us to lower intact PTH levels without driving serum calcium levels through the roof.
We have merely identified the tip of the iceberg, and I believe over the next 5 to 10 years, emerging science and innovative therapeutic techniques which target at the cellular level some of these abnormal mechanisms will be really very important.
In the next 10 years, I would hope that we can come up with ways to decrease our patients' coronary vascular disease risk and also improve their mortality. While we have come up with a lot of different agents in the last 10, 15 years, the patients still have an excess cardiovascular burden, and hopefully we can improve this in the next 10 years.
I think one of the most important changes that can occur over the next decade, again, goes back to early identification of these at-risk patients.
I think if you start to look at hospital admissions and discharge summaries, you will see that CKD is now being listed as a diagnosis, where before, they might mention some early renal insufficiency. This is in part a lot because of the 2002 classifications of chronic kidney disease, which was huge, that was published by the National Kidney Foundation, putting the stage of chronic kidney disease into a category and assigning that to a patient protects them.
I think what the future holds for us is that the nephrologist can identify that the earlier stage CKD patient, measured by maybe a specific GFR level, is going to be that trigger that gets them to think, wow, this is a patient that something needs to be done for. I need to think about the therapies, the drugs that I might give to them, and in trying to prevent disease as opposed to just symptomatically treat it. So we believe that we have the most robust renal pipeline in the industry. We have active programs in polycystic kidney disease, FSGS, diabetic nephropathy, and acute kidney injury. There's a very large number of patients that are currently diagnosed, or many of them that are not yet diagnosed, with earlier stages of CKD that are yet to be identified.
We've been successful. We've been successful in understanding what our purpose is. And it is exactly that we have to sustain. There is no doubt that is our purpose. That's why society is supporting us. To sustain this, to continue to have this culture of collaboration, cooperation, sense of purpose, sense of urgency, we need to stay very, very, very close to really understanding that it is not about us, that it is really about the patient.
My kidneys is fine, and all my lab work come back every time. Good. Well, I'd like to have my grandkids over, and I barbecue for them, and that's one way of getting them over here, was just barbecuing for them, and then we have a good time. I enjoy them.